everyone, this is Sarah Kyleman from the Education Subcommittee of the Cancer SIG. Thanks for joining us today for our Cancer SIG webinar. I want to remind you all that we have received approval from NSGC to offer CEUs for the 2016 webinar series. We are keeping track of attendance for each webinar and journal club presentation. The Cancer SIG itself is keeping track of that so that at the end of the year we can actually help you figure out which of these you attended. You do need to take a survey after each presentation in order to receive CEUs, however. The survey will be available as soon as the presentation ends. If you're unable to take it at that time, we are going to have an email sent to you from gotowebinar.com with a link for the survey in that email. We have had technical issues the very first month of the webinar series, but everything seems to have worked out. So let us know if you have any bugs or if you don't get a copy of that survey sent to you. Today's journal club topic is risk-reducing Salpingo oophorectomy for hereditary breast and ovarian cancer syndrome. This will be presented by Andrea Foreman. Andrea has been a cancer genetic counselor since graduating from the Mount Sinai program in 2004. She's been at Fox Chase Cancer Center since 2008, where she's been involved in both clinical care and research. Andrea also teaches the Introduction to Cancer Genetics course for Arcadia University's Genetic Counseling Program, and she's currently co-chair of the Research Subcommittee of the Cancer SIG. As Andrea presents today, feel free to type your questions into the questions or the discussion boxes as you think of them. At the end of the presentation, Andrea will answer whatever questions you have, and there will be some time for discussion. Each participant is currently muted, but I can easily unmute you during the discussion if you'd like to actually speak to Andrea directly, as opposed to typing your questions into the box. So thank you again for joining us. Andrea, you can take it away.
Okay, thank you very much, Sarah. So hi, everybody. I will admit that this is my first time giving a talk where I can't see my audience. I prefer to see the whites of your eyes and hear you chuckle at my bad jokes, but we'll make do, and hopefully I can keep things fairly interesting for you. So I thought about doing this topic on Salpingo oophorectomy for a couple of different reasons. One was that there have been some recent updates to NCCN Guidelines that I felt were worth touching on. And the other was that there has been an article that came out recently, or about a year ago now, that really looked at, kind of questioned whether the breast cancer risk reduction that we have kind of historically been quoting as what I think of as a consolation prize with a premenopausal oophorectomy may not be as significant as we thought it was. And I needed an excuse to dive into that more to figure that out, and so I figured that forcing myself to give a webinar on that topic would help me do that. So thank you for giving me an excuse to get into this. And I figured just for fun we'd throw in a little bit of talk about salpingectomy. So I kind of figured we'd cover the ovaries and the tubes overall all together today while we were chatting. So I am sure that the vast majority of you are very well familiar with the NCCN guidelines related to high-risk breast and ovarian cancer syndromes. If you are not, this is a free resource. You just need to make an account through the NCCN website, and you will have access to these wonderful updates. They do get updated at least twice a year typically with input from physicians and genetic counselors from all over the country. And what they're sort of doing is reviewing the latest literature that is published on both determining who should have testing for certain genetic syndromes and then what medical management should be recommended for those who might test positive. And it's a nice, they do all the hard work for us. So that's kind of how I view it. I go to look at what they recommend, assuming that they have done all the lit searches and hard stuff that goes along with figuring out the best plan for these patients. So they did have some updates in this early in the year. We're at version 2 already. There were just mainly some clarifications they wanted to make in version 2. But there were no big surprises. Most of this is in line with what we're all familiar with. Generally, we think of ovarian cancer risk reduction primarily with mutations in either BRCA1 or BRCA2. BRCA1, the age to consider risk-reducing Salpingo oophorectomy is between 35 to 40 and post-childbearing. Now, BRCA2, I don't know if this is the first year they brought it up, but they did kind of say you could delay that surgery a little bit, maybe to 40 to 45 years of age, but they emphasized if that person had already had a bilateral mastectomy. And I suspect that's because of the reported benefit from doing a premenopausal oophorectomy and the reduction in breast cancer risk that has typically been felt to go along with that. So we're going to see a little bit of question to whether that mastectomy is still relevant here. And of course, as genetic counselors, we know that discussion about risk-reducing Salpingo oophorectomy should include a couple different topics, including, are you done having your kids? Are you hoping to have more children? The menopausal symptoms that can go along with that, and consideration of hormone replacement therapy, which generally is thought to be pretty safe short-term for people who've had a premenopausal RRSO. What the NCCN also emphasized is that we still don't have data supporting ovarian cancer screening. This isn't new to any of us, I don't think. Transvaginal ultrasounds and CA-125 are just not sensitive enough for them to recommend it, but they do kind of say, you know, offer it at your own risk. So if a clinician really wants to do that, he or she could consider offering that at 30 to 35, but not generally considered a recommendation. So no big surprises there. What was a little bit new is that the NCCN has started looking at multi-gene panels and the genes that are included on some of these panels, and considering whether or not some of these genes have enough risk to support additional medical management changes if positive. So breast MRI now has some extra genes included. Risk-reducing mastectomy, PALB2 got bumped up to consideration of risk-reducing mastectomy. And then we had 3 new genes added to recommend or consider RRSO. And so this is the BRIP1 gene, RAD51C, RAD51D. I spent about a week getting BRIP1 and BARD1 mixed up in my head, just personally, but as a little mnemonic, it's the gene that's BR, just like BRCA1 and BRCA2, and that has helped me make sure that I'm always looking at the right ovarian cancer gene. So maybe the rest of you don't struggle with these abbreviations, but I do sometimes, so that's my little trick. So now we have 3 new genes that prior to this update, we really weren't considering these to be clinically actionable genes. And now they are. I mean, now there's a reasonable, respected set of guidelines that suggest a person who carries a mutation in any of these genes listed should consider risk-reducing Salpingo oophorectomy. And they actually have a nice little summary. So this happened to have just come up on the listserv about an hour or so ago. But this is actually in the guidelines. I didn't bother to put the specific references because if you've never flipped through to the end of the NCCN guidelines, there's this whole section where they actually explain their justifications for why they're recommending things. And it has references to the specific literature so that you can kind of rest assured this wasn't just something that they made up one day when they were feeling bored. So they summarized BRIP1. I believe we had a talk a few months ago about these genes, so I didn't spend a whole lot of time on these, but just to summarize the data, it's a lot of numbers, but I'm going to walk you through it. Essentially, BRIP1 has been found to be a little over 1% of unselected ovarian cancer cases. So this came out of the Walsh paper from Mary Claire King's group a few years back, right around the time panel testing came out. So not particularly common, but still a portion of those. And the relative risks and the RR and the OR are pretty high. So, you know, there does seem to be a pretty significant risk for ovarian cancer with somebody who's positive. Kind of approaching, you know, it's hard to apply a specific percentage to a relative risk, but probably at least 10% risk for high-grade serous ovarian cancers. So, and these were statistically significant numbers and, you know, really suggest, hey, this is not just a tiny little blip in risk. It's important to manage that risk. RAD51C and RAD51D together were another 1% of cases, so they're a little more rare than the BRIP1. And the relative risks are a little lower, but I will draw your attention to the jump that we get when we add family history. So when they broke it down and not just, okay, everybody who's RAD51C positive, but instead said everyone who's RAD51C positive and has a family history, particularly of ovarian cancer, we really saw a big jump in risk. Now, I will point out that the confidence intervals are very wide with these, I mean hugely wide. So we definitely need more data. These were each relatively small studies, not huge numbers of people, so we definitely need to clarify this a little bit more. You know, we don't want to dismiss a RAD51C positive in a family that doesn't have ovarian cancer and then end up with the first person to get ovarian cancer. So it's still a little bit unclear, but it was a high enough risk when you put all of it together that NCCN felt, hey, these 3 genes are important and you need to be thinking about risk reduction if you find these in any of your testing. If you want to read more about it, section NS 17 and 18 in NCCN Guidelines is where you'll find that. So I also noticed a really nice review article that came out in the New England Journal of Medicine this year, and I am a huge fan of review articles. Again, apparently I'm just really lazy. I don't like to do my own research. So review articles, I let these smart people, Dr. Lindor has done some fantastic publications. I let them go through all of the research and then summarize it for me because I'm a big fan of tables and summaries. So this particular article went into both breast and ovarian cancer medical management. We're only going to be talking about the ovary information right now. And in short, it kind of supported a lot of what we were seeing in NCCN, which makes sense because these were probably the same studies that they were looking at. I will say that perhaps I've gotten overly comfortable in sort of the numbers that I learned as I've in my early days of genetic counseling, but I was surprised to see that on average, the ovarian cancer risk reduction with the Salpingo oophorectomy is lower than I expected. At 80%, 80 to 90%, and I've been quoting 96% or so, which I'll show you isn't exactly wrong, but I'm going to show you kind of where those numbers came from. So it's maybe not as great as I thought it was. Maybe you guys are better on top of these things than I am, but you know, it's not perfect. I mean, we all know nothing is, but I was a little surprised the risk reduction was not higher than that. Now here BRCA2 also they felt was reasonable to delay until 45 because of the low risk of cancer, of ovarian cancer before age 50. They didn't specifically mention whether they wanted you to have a mastectomy before or not. And then they did touch a little bit on including hysterectomy with Salpingo oophorectomy. This comes up sometimes with some of the patients, oh, you mean I don't have to get my uterus out? They didn't get into some of the data that's come out about those more aggressive uterine cancers that have rarely been found in BRCA positive patients, but they did point out that a full hysterectomy could simplify hormone replacement options. You don't have to worry about a uterine cancer risk with some of the hormone replacement if you don't have a uterus. But they didn't really go so far as to make an opinion either way. So I mentioned tables. This is a nice table that they did that summarized some of the past studies that have looked at removing the ovaries and the fallopian tubes and what did that do for ovarian cancer risk. And here's my 96% reduction. So I didn't pull that out of thin air. That's based on this Rebic paper. But you'll notice that the other ones are more in the 80 to 90% risk reduction. This one's only about 72% risk reduction. So there is a little bit of variability into just how low is your risk of essentially primary peritoneal cancer with a risk-reducing Salpingo oophorectomy. But still obviously a significant benefit to the surgery. So I don't want to diminish that, but if you've been hyping it as much as I have been, you might want to temper your numbers a little bit. Now, the bigger question that we're kind of getting into now today is the risk of breast cancer after Salpingo oophorectomy. And so this table, again, it's a little busy, but you've got your hazard ratios over here, and they all run around a 50% risk reduction. So 47%, 53%, 72%, significant reduction in breast cancer risk if you have your ovaries out, generally, premenopausal. We don't get into the details here. And then we have this study, which was published last year from a group out of Denmark. And we're really not seeing much of a risk reduction here. We're not really seeing any risk reduction here. And this was a bit of a surprise, I think, when this got published. Those of you who have good eyes might see here that there does seem to be a benefit for BRCA2 carriers, but the confidence interval, we cross 1. It's not a very reliable number, and the authors actually kind of acknowledge that. So this is the paper. If you want to look it up, it's a bunch of Dutch names, and let's explore a little bit about what exactly they were doing. So they actually went to 4 well-respected papers on breast cancer risk reduction after risk-reducing Salpingo oophorectomy. These were the 4 authors that they looked at. And they took the method of determining that risk, and they applied it to their own cohort, their own Dutch cohort. And they actually got pretty similar numbers, about roughly 50% reduction in breast cancer risk. But then they went back and they reanalyzed this with some extra controls. And the 2 things that they focused on, one was called cancer-induced testing bias. So essentially these would be patients who the whole reason they underwent testing was because they were diagnosed with a breast cancer. Okay, so I hope you guys can still hear me. Okay. So the cancer-induced testing bias, so the whole reason these patients underwent genetic testing in the first place was because they had been diagnosed with breast cancer. Now, if you include those patients in your analysis, you may actually be lowering your breast cancer risk because these patients have already had a breast cancer, or the risk of a second breast cancer may not be as elevated. So that was one of the arguments that they made. I don't know how much that applies, but that was one of the things they were concerned about. They also went into something called immortal person time bias, also essentially known as survivor bias. I spent a lot of time on Google trying to figure out what this meant to a normal person like myself. It's not real obvious. Essentially, what can happen is that if you, person time, I'll give you an example. And I found this online, so hopefully it's a reasonable example. So if you're going to do a genetic test and you're going to draw blood between the time, you're going to draw blood after a patient has been diagnosed with cancer. So you're going to have a period of time from their diagnosis to the actual time when they have their blood drawn, and that is called person time. And it can be immortal because you're only going to draw blood from the people who survive long enough to give you that blood. Okay, so if you have somebody who dies before they have a chance to give you blood, it's going to kind of cause a bias of some kind. And what tends to happen is that if you don't account for this, you have an upward-based survival curve, you have downwardly biased outcomes. So essentially, you make your data look better than it should. I'm sorry I don't have a better explanation for this. I have a little bit more about it on the next slide, because this was something that took me a long time to wrap my head around. But apparently, it's very common in epidemiologic research, and it's very difficult to adjust for, or it's often not adjusted for. Now, when they reran their own results, so remember, they've already analyzed their data with sort of the classic way that had been published and had very similar results to the classic results. When they accounted for these additional controls, they basically saw no breast cancer risk reduction, which is somewhat terrifying. At least I thought so. Again, there was some evidence that maybe BRCA2 carriers had a benefit, which would sort of fit. We might think that they are more influenced by the hormones that the ovaries are getting off premenopausal. But they had really low numbers in that population and a really bad confidence interval. So they wouldn't even claim that as actually showing any benefit. They did point out they had their own limitations. There wasn't a really long observation period, although they said it was comparable to the other studies. They did exclude people who had already had risk-reducing mastectomy. And they noticed that a lot of young women ended up in sort of the non-risk-reducing Salpingo oophorectomy group, partly because they were young, and many of them also went on to have a mastectomy, which would actually sort of exclude them from this because we couldn't tell if they ever developed a breast cancer. So there were some limitations, and they were pretty straightforward about that. But it kind of rocked everything. Now, if you're feeling particularly turned around about this immortal person time thing, I did find this random editorial. This is in an anesthesia journal. And they did have an example. A mortal time bias. Let's say that you had a group of seriously injured patients submitted to the intensive care unit, and they were offered tea and crumpets on day 3 of their stay. Now, can you tell that this is written in Great Britain and Ireland? There's a clue there. So day 3, they get tea and crumpets, and then you analyze who does better, and you find that the people who had tea and crumpets did better than the people who didn't have tea and crumpets. But if you start your analysis from the time somebody was admitted to the hospital or admitted to the ICU, you're going to include particularly severe cases of patients who didn't survive to day 3, thus never got their tea and crumpets, thus fall into the no tea and crumpet group, but died, and so they look like a worse outcome, when in reality you're biasing your crew, your assessment to the people who lived long enough to get the tea and crumpets in the first place. I hope that made sense. Again, I went around in circles in my head, but if you're interested, you can look this up online. You can read this whole article. It's always fun to read something from our friends across the pond anyway, and how often you get to use tea and crumpets in an example. So, okay. Now, I will point out that there have been at least one other publication that I found that did also sort of challenge this question of how much does the breast cancer incidence drop after VSO. And it was a fairly straightforward study. They had 162 BRCA carriers who, at an average age of 41, had their risk-reducing Salpingo oophorectomy. And they essentially said, we know that we should get X many number of cancers if you're positive, and we know that your risk should be half of that if you had a risk-reducing Salpingo oophorectomy at 41. So we're going to cut that expectation in half, and then we're going to compare it to the number of cancers that we actually see. That's a kind of simplistic study. I love that that's a study I can follow. What they found was in their BRCA1 carriers, they found 12 new breast cancers after their surgery, compared to 5 that they expected. And they did take anybody who was diagnosed within like 6 months of their oophorectomy because they felt that that could have been a cancer that was there prior to their oophorectomy. The BRCA2 carriers actually did show some benefit. They only found 1 breast cancer compared to 3 that were expected. So again, maybe there's some evidence that this breast reduction is primarily in BRCA2 and not so much BRCA1. But again, this sort of raised that question of just how much risk reduction do we actually get for the breast when we're taking those ovaries out. So now everything we think we know has been turned upside down. And I picture our scientists looking a little bit like this. And there was a response. So Domchek and Koff and Rebick and all these original authors came back and they said, you know, well, nanny, nanny. No, I'm just kidding. They were all very respectful to each other, of course. And but they did have some questions about the way the analysis was done by the Dutch group, and not being a biostatistician, I'm not going to get too much into that. What they did do, though, was they kind of re-examined their own data, and they compared, they did it the Dutch way, the Heemskerk-Gerritsen way, versus the original approach, and they kind of did it with 2 of the papers. And their hazard ratios really were pretty similar, no matter which way they analyzed it. You know, there really wasn't significantly different. So, you know, again, it brings up this question that maybe this issue of the bias, maybe it's not as big of a deal, assuming that they were able to account for it in the same way that the original Dutch paper suggested and still show the benefit. Maybe this isn't as much of a loss of of risk reduction as we thought. So when it all comes down to it, we still don't know. There's no black and white. I would like to see more. We have several papers showing a risk reduction. I would need to see more papers showing maybe there not being such a risk reduction. So we need a little more data. And you know, this always makes me think that statistics, I think, is like a game of whose line is it anyway. Everything's made up and the points don't matter. It's hard to know sometimes. We're putting a lot of faith in these biostatisticians that they know what they're doing, and I think usually they do. But it is kind of interesting to think maybe we're not looking at it the best way that we can. So we're going to need a little more investigation into that, and we'll have to wait and see. So, you know, when we're thinking about risk-reducing Salpingo oophorectomy, as a counselor, you know, what is our goal here? Our goal is generally to reduce the risk for ovarian cancer, and clearly that surgery is the best option we have for that right now. So it doesn't really change that. I think it mainly comes into question regarding age recommendations. You know, BRCA1, when you look at the meta-analysis that was done by Chen and Parmigiani back in 2007, the risk in BRCA1 by age 50 is almost 10%. And so you can see where there is, just based purely on risk, some reasonable justification to do a premenopausal oophorectomy in that group, whether or not you get a breast cancer risk reduction. But with BRCA2, that risk is closer to 2.6%. Some studies suggest even lower to age 50. Well, so from an ovarian risk standpoint, there's not a lot of reason to do the oophorectomy premenopausal. But if there's a breast cancer benefit, then maybe there is, and that's what's a little bit at question right now. So just kind of something to be thinking about when we think about the ages that we're going to recommend these procedures. You know, at the moment, I'm still kind of going with NCCN and what they say, but critical thinking, you know, we want to be keeping an eye on those numbers as more data comes out. And then, of course, there's a question of how much do we communicate to our patients. They're oftentimes already overwhelmed by information, so how much discussion about limitations are we going to get into? I don't really know. I mean, again, if the goal is reducing ovarian cancer risk, we still need to do that. If there's a lot of debate about when, that's when we might need to get into a conversation about some of the conflicting data. So just some thoughts for us on a end of the day here on the East Coast. So changing topics, salpingectomy is something that is sort of on the edge of our awareness right now. NCCN does kind of state that it is still not the standard of care. There is still concern about the risk for ovarian cancer risk if you only have the fallopian tubes removed. And of course, they point out you lack any breast cancer risk reduction if that's all you do. But now we have this question of maybe the breast cancer risk reduction, maybe that shouldn't be the deciding factor. I don't know. So again, we're adding another level of complexity to this decision making. The Society of Gynecologic Oncology does state that it can be considered, salpingectomy can be considered at completion of childbearing if they do not agree to Salpingo oophorectomy. But they emphasize it's not a substitute for oophorectomy, which should still be performed as soon as the woman's willing to accept menopause, preferably by age 40. And you know, unless the family history is particularly striking for a really young ovarian cancer, I don't see a lot of justification for doing a salpingectomy at 35 if you're going to have to turn around and do an oophorectomy at 40, as opposed to just doing it all at 40. But there you have it. That's the statement. And then the nice review article I mentioned earlier with Hartman and Lindor, they basically said there's not enough data yet. And that's basically where we are. There just aren't studies. I did a PubMed search. There's really not anything out there of actual outcome data. There are several clinical trials and groups who are looking into this, so I'm really hopeful that we'll have some data soon. But for now, we're going to just kind of sit there. No, it's fine. I'll wait. Whenever you guys get around to it, whenever we can finally get this information, we'll take it. There was a study, though, there's been at least two, but we'll talk about one in the UK that was looking at sort of the clinician viewpoint about this. You know, what are the docs and the the gynecology specialists and genetic specialists in the UK, what are their attitudes towards risk-reducing, Salpingo, I forget what something like denied oophorectomy, so basically taking out just the fallopian tubes and not doing the ovaries. And the respondents in general agreed with the tubal hypothesis for ovarian cancer, which is the entire basis of doing salpingectomy alone, which is that most ovarian cancers start in the fallopian tubes, not in the ovary cells. So there seems to be a fair amount of consensus that that's likely, but I do think there's still a question of, is it all ovarian cancer start in the fallopian tubes? What percentage? We still don't have great data on. About half of the respondents agreed that the evidence just wasn't strong enough to introduce this into clinical practice. I'm kind of curious what the other half are feeling, since they must feel that there is some evidence enough to just do this on a routine clinical basis. There did seem to be a consensus kind of in line with the Society of Gynecologic Oncology that says, well, if they're not willing to have the ovaries out, the Salpingo oophorectomy is better than nothing. So there were several people like that, and then many people supported doing this through a clinical trial. So that's certainly one avenue that we can try to offer our patients. I actually didn't think to put together a list of active clinical trials right now for salpingectomy, but I'm sure that that's something that you could look up if you were interested. And actually, that kind of takes us to our next topic. So this is going to be, I already know we're getting close to the end, so this is going to be a pretty short talk today, guys. But it will leave us some time to chat. But before we get to that, I did think it was worth sort of exploring the patient's viewpoint on salpingectomy. So I went to the Force message boards, and I did some keyword searches for tubes. That tends to be the terminology that the patients are using more often, salpingectomy, fallopian, and found a few sort of stories or tidbits that were shared by patients. So this person was just recently posted, and she actually had a pretty good understanding of the limitations of salpingectomy alone. So she asks, has anybody thought about getting just their tubes out? Are there any clinical trials? She's even stated that she knows that rather than the ovaries being the source of ovarian cancer, she knew the data was new. She knew the doctors were not recommending salpingectomy alone at age 41, so she's 41 and she's thinking about this. But then she also states that she just found out 6 months ago that she's BRCA1 positive. She's not ready for surgical menopause. She's got 2 little kids. She's working on a career transition, and she's kind of like, can I just do this? Can this just be a temporary step that I take and not go through menopause on top of everything else right now? And she recognizes that it doesn't reduce the breast cancer risk. So, I actually really appreciated this one. She'd obviously thought through this, but I think it really illustrated the challenges that the patients are trying to balance in balancing their real life with their risk, and trying to minimize their downtime and minimize side effects and minimize their lives being any crazier than it already is. And to be honest, this is a person that I probably would support a salpingectomy with appropriate follow-up because she clearly understands the limitations, and I feel like she would be a person who would likely come back in 10 years to have those ovaries removed. I think the fear about salpingectomy is sometimes that the patients will have that surgery and then never be seen or heard from again. And you'll never know, do they get those other ovaries, get the ovaries out, or do they just think, do they misunderstand, think they've reduced their risk enough, go on to live a life without worry, and then get hit with an ovarian cancer 10 or 15 or 20 years later. I think that's the big nightmare scenario that we're all worried about. But you can make an argument that if a woman understood those limitations and she's in a situation with appropriate follow-up, maybe the 2-step process is a nice compromise. So another conversation that happened, this was an ongoing conversation. I actually went back to 2010 where I found this woman who I suspect is probably she was a bit revolutionary. She was on a quest to find somebody to do salpingectomy, and again, this was 2010, so we're talking 6 years ago. And she relayed a bit of her journey and how difficult it was for her to find a physician to do this, although she did finally find somebody. And that thread has kind of continued to go on over the years, and people have added to it. And when something that did come up was a lot of people talking about maybe just keeping one ovary. So essentially a salpingectomy, take the one ovary out, but keep one ovary to help with surgical menopause. So this person relayed, I would have done my mastectomy first. So again, she's thinking about the breast cancer risk reduction here. She would have kept one ovary because to her the surgical menopause was just horrible. And she feared breast cancer more than ovary, so she kind of wishes she had taken a different path. Somebody else is actually scheduled to do just that. She can do one ovary, both fallopian tubes. The doctor wants her to do both. She'd already canceled surgery once because of concern and anxiety over side effects. So, if the difference is she doesn't do anything, maybe this is a little bit of a confirmation. But she recognizes, too, that she might be being short-sighted here. So, these, at least here in the forced form, these women are not going into this blind. And they were getting pretty good feedback from other patients, including some women who were pretty, not supportive of that so much. So one BRCA, one carrier, this is the same thread, but now we've gotten a few years on. One patient related how she got ovarian cancer at 36, and it developed on the surface of each ovary. So to her, that was a good argument for not leaving those ovaries in and doing hormone replacement therapy instead. And somebody else did the salpingectomy, and she seemed to have had some pretty serious side effects, which has been a concern, although there have been multiple publications that really showed that the risk of like premature ovarian failure and some other side effects weren't particularly elevated in the salpingectomy alone group. But for her, she did. She had some pretty significant issues. And she really thought this was going to be nothing, but in reality, she seemed to have had some side effects almost comparable to what she might have had if she'd had the ovaries out at the same time. So she wishes she had just kind of waited and then done the whole shebang all at the same time. So that was one thought. So that, my goal here was just to kind of show you that this is on patients' minds. I think we've all had patients who've brought it up with us. I think it's going to become, especially if you send your positive patients to FORCE as a resource, they're going to see these threads, and so what might not have come up in a counseling session may come up to be an issue later. I give a lot of credit to Sue Friedman because as I'm reading through these threads, she would pop in. She always had a really empathetic response to the patients, but she was also very rational, and she was quick to point out, we're working with this group on this study, and kind of giving options for patients. So she was, this wasn't, these forms are actually really nice. It wasn't like wild and crazy statements from patients. Things were pretty rational. People were very supportive, and we had the moderators of the forums who would come in as well and provide a little options for research studies and clarity, which I thought was really nice. So just something. You're welcome to explore the FORCE discussion forums yourself. It's not a bad idea if you refer patients there. You should kind of know what you're sending them into, but you can log in and just kind of see what people are talking about. So if you're wanting to get in the mind of the patient, sometimes it's tough for us. We see a patient, and then we see them for their results, and then we may not ever really talk to them again. So it's kind of nice to know what they might be seeing as they continue their journey with their positive results long after they're out of our office. So anyway, I was a little disappointed not to have more about salpingectomy to offer you guys today, but that's kind of where we are. We're waiting on the data. So we're going to sit and wait until that happens. We'll have to do an update then. But I did think that this whole concept kind of brought up some thoughts for me, and I was curious kind of what other people were thinking. The NCCN guidelines, so the NCCN guidelines are really, to me, important. And I really am not offering BRCA alone anymore to most of my patients unless they have a particularly high anxiety about variants and such, because we can officially say that these other genes are going to change medical management. And we don't have a lot of outcomes data. You can make an argument. Insurance companies don't always like it. But if given the choice, I would prefer to do at least a guidelines-based panel that would include your RAD51C and your BRIC1, your PALB2, et cetera, because I do think if it's going to affect your medical guidelines and we don't have separate PALB2 criteria or separate RAD 51D criteria, then personally I prefer to bundle those and get all of that information that's actionable. Whether to go on to a bigger pan-cancer panel is a whole other conversation, but to me my minimum at the moment, unless there's a really good reason not to, is to offer a guidelines-based panel. So I'm not sure what other people think about that. And then the question of the breast cancer risk reduction, I'm kind of curious if you think this might change your conversation with patients about risk-reducing salpingo oophorectomy. Again, I hesitate to overwhelm patients with information, but it kind of comes down to the biggest issues that you might be seeing with that patient, of course, but I'd be curious to know how much of this you would volunteer to the average patient. And whether or not salpingectomy has been on the mind of you as a counselor or your patients, if you're seeing a lot of interest in it. You don't necessarily have to type in your responses in the comment box about these, but these are all just kind of thoughts that I figured get these questions in your mind and see what you guys thought about them. But that's really what I had to cover today. So I'm happy to answer questions as best I can. I will caution you that if you're going to ask me about the statistics, I'm probably not going to be able to help you much more than what we've already talked about because I struggled with this. It was a good exercise for me. Like I said, I was curious about these risk studies, so I got to dive into it a little bit, but I would by no means consider myself an expert. So if anybody else knows more and wants to clarify anything I said, feel free to jump in with that as well. But otherwise, I'm happy to take questions. Thank you.
Thank you so much, Andrea. That was a lot of work that you put into that. I appreciate you being so concise and giving us all that information. The first question is actually from Deborah Collins. She was wondering if there's any data on salpingectomy on all postmenopausal women having any abdominal surgery similar to having your appendix out with or without BRCA status in order to just reduce ovarian cancer risk.
Yeah, it's a good question. So I had a couple of those papers saved, and then they didn't really get into what I was looking at, which was from a risk reduction standpoint. So I skimmed them, but I would have a hard time telling you what they said. But I do think that there has been, for women having a hysterectomy, I know that it is recommended that the tube definitely be removed at the same time. I mean, they're sort of attached. You would think that's not overly complicated. But there has been some question about, like with tubal ligations, if you're going to have a tubal ligation, might as well take out the whole tube. And that's where some of the data about complications from salpingectomy came from, I think was in groups where you did either a tubal versus the full fallopian tube removal. The complications were about the same. It wasn't any worse. So people are looking at it, and I think there is some thought of, hey, if you're going to be in there anyway, take them out. There doesn't seem to be any particularly increased risk for salpingectomy if you're already going to be in there with the uterus or the tubes. I'm not sure in relation to other abdominal surgeries like gallbladder or appendix, like if you're in there, I don't know how close they are to each other, how easy it is to add one on if you're doing the other. I'd have to do a little more digging on that.
That was a wonderful lead-in to one of our next questions. When women have their tubes tied, how much of the fallopian tube is typically removed? Are any studies on these women and reduced risk for breast cancer for BRCA positive status?
Yeah, I don't know, actually. I don't know about how much. I'm really not even sure how a tubal ligation is performed. So I really can't speak to that. I'm sorry.
It's okay. It's a very interesting question. On BRCA prophylactic BSO TAH surgeries, how often is the tumor only in the fallopian tube?
You know, I should have looked that up. I actually did not get into the tubal theory in detail in prep for this talk. So I'm really not sure what those percentages are. I would hesitate to even take a guess at it. You know, all I can say is it's significant enough that they're really starting to considered just taking the tubes out. So to me, that's got to be a pretty high number, but I couldn't put a number on it.
I completely agree with you. Kind of the same experience as just being in clinic. It was happening often enough that we got to this point, so it must be significant. Robin Palmer said, "Excellent, Andrea. Can you address ablation versus ectomy?"
Oh, God. No. No, I'm sorry. I didn't, I didn't get enough into sort of the procedures themselves for my own edification, so I'm sorry that I can't get too much into those details. I'm failing you guys. I'm sorry.
You are not failing us. We're all just very curious, and we all want more information. Just kind of what we're saying. We'll just sit here and wait. Give us the info.
We're used to that.
Do any of the DSO and PPC studies evaluate who did the surgery and if it was performed in accordance with the current recommendations, like washings, close inspection of the intra-abdominal organs, serial slicing of tubes and ovaries, all of that kind of
stuff? Oh, excellent question. I don't know enough about the studies that have been performed, but I do know that when you look at NCCN, it specifically states that if you're going to be doing a risk-reducing surgery, that you need to follow these guidelines. There was a phrase that one of the patients on FORCE used, and then I saw it again in NCCN, but I'm blanking on what the abbreviation was. So I know that both SGO and NCCN do recommend that you follow a very specific protocol with the pelvic washing, the assessment of the tubes and ovaries to determine the presence of, potentially an occult cancer. In the studies themselves, though, I'm not sure. I have to assume, well, I shouldn't assume. You should never assume. It's a dangerous thing to do. But I would hope that they were following a very structured protocol, but I don't know for sure.
Okay. Can you comment on how you counsel patients who are found to have RIP1, RAD51, C or D, variants of uncertain significance, who have a family history of ovarian cancer? In a case she's working on specifically, it's a second-degree relative with ovarian cancer.
Yeah, those are always tough. I mean, I really approach it the same way I would any variant. We see that with BRCA, of course, where you can have a history of ovarian cancer and a BRCA variant. We really do treat a variant as the same as a negative, meaning we make recommendations based on the family history. Second-degree relatives are tough. At our center, we're pretty cautious. We do tell patients with a first-degree relative with ovarian cancer that if they remain concerned about their ovarian risk, while it is significantly lower than we would expect if they're gene negative, we still would, if they remain concerned, they could consider an oophorectomy, particularly if they're postmenopausal. There's no official guidelines about that. We go a little rogue with that. Second-degree relatives are tough if there's a maternal, female in between who didn't have cancer. I think it would depend on patients' anxiety levels and age. It'd be hard to justify premenopausal oophorectomy for a variant with a second-degree relative. That would be very unlikely for me to be thinking about that on a personal level.
Okay. Kathleen McCann was very helpful, and she let us know that on the question about tubules, a lot of the time the tubes are cauterized and closed without cutting out a piece.
Awesome.
To kind of help us with that. Yes, thank you. All right, last question. Since BRCA2 carriers with mutations in the OCCR have a higher risk for ovarian cancer, was there any data of when those individuals should undergo risk-reducing DSO, or should it be based on family history possibly?
Yeah, that's a good question. So I really have not seen that particular region referenced when you look at these studies. So yeah, you're lucky if you get them to break out BRCA1 versus BRCA2. If you look at some of the tables that I had, they just kind of gave a generic risk. So if we go all the way back, it's like, these were all just, they combined it. I mean, you didn't even get any BRCA2 numbers here, which I don't know if it was just a low number to reference or what. So it's not something that I've seen. I'd be curious. I know the risk is higher with that region. I don't know if the risk is younger. I don't know enough about that region to say for sure, but I think family history is always a guide. Obviously, if your family history is more aggressive and younger and stronger, then your recommendations are going to be more aggressive. Yeah, so.
I think she had thought there was data against OCCR. Did she make this up, possibly? Do you have any idea? Are you aware of any data suggesting not to do that for OCCR?
I don't know.
Okay. We do have a question about your slides. We are going to be posting them to the Cancer SIG website, yes. These presentations have been so valuable to a lot of members. We're going to try and keep putting slides up every month along with the recording of the webinar. All right, one more question that popped in from Scott Weissman. Given your review of the data for this talk, do you have any thoughts on NCCN making the recommendation for risk-reducing Salpingo oophorectomy in RAD51C and RAD51D carriers based on the studies determining the odds ratios more so than RR?
No, I mean the odds ratio versus the risk ratio, they weren't dramatically different as I recall. I think that family history issue comes into play, and again, we had some similar data with PALB2 where if there's family history, the risks went up significantly, and I have a really hard time knowing how to apply that clinically. Because at some point, when you do get that first person with the cancer, then does the entire family risk just magically change? I don't know. I can tell you that I happened to be down at the NCI last week, and I was talking to some people who work on models, risk models, and one of the things they're trying to investigate is incorporating not just the gene mutation, but the family history to help guide risk. So when you do have we sort of do that indirectly, a more aggressive family history, we tend to screen medically more aggressively, but to try to put some more clarifying numbers on that, but I'm sure that's all very early stage. So no, I would not dare to guide the NCCN. No, the risks, again, they're pretty similar, other than when you throw that family history in. If it's a matter of a few percentage points, I don't know that it's dramatically different.
Well, that appears to be the last of our questions. I think we can probably go ahead and wrap up. Is there anything else you wanted to close with, Andrea?
No, it'd be cool for the people who attended today. We've been struggling with time for these webinars, I know, on trying to incorporate, making sure we can get our friends in Hawaii and California. For me, end of day was really nice because I'm mostly done with my day on the East Coast. But, there seems to be preference. I think feel free, people, to kind of email us or let us know if you had a preference on times, because some of ours are more mid-afternoon and other time points. So as we plan these moving forward on a monthly basis, we'll take that into account.
It's a good idea. We have no qualms with doing them at different times on different days. We just try to go with each month what the presenter prefers. So absolutely, feedback is welcome. Okay, well, thank you so much, Andrea. That was really pretty wonderful. So we'll post these slides up as soon as we can. And if anyone has questions, just let us know, okay? All right, everyone have a good day.
Thanks, everyone.
Bye.